perform again, because after end of this last session, we'll pick 3 lucky person to have the shirt. And for the today last session, it will be head to toe common sonographic scanning for pain medicine, the live demonstration. We have the short lecture and then the ultrasound scan. Dr. Nanason Sin Bunyakun will be the moderator today.
I'm not sure what happened with the microphone, but really apologize about that. But anyhow, let's do the last session. It's just head-to-toe scanning. I know that I'm a little bit too greedy to put like a lot of scans in 1 hour. We plan for 7 scan, a brief review, and the scan. But if we cannot make from head to toe, we probably can stop at from head to butt. That is fine. So this session, we are from 3 countries. Dr. Kalana Lee from Hong Kong, Dr. Donald Tang from Taiwan, and me from Thailand. And then, first of all, I would like to introduce Dr. Tang. He's from University of Taiwan at Taichung, and he's a rising star in ultrasound-guided pain procedure. And you know that there is an ASTRA examination for chronic pain, ultrasound-guided chronic pain procedure. Only 3 people in Asia that got this certification, and he is one in that 3 people. The second one that I would like to introduce, actually there's no need for introduction. Dr. Lee, thank you so much for coming here. If 2 of us are Jedi, she is the Yoda. She is like a master of all of us. But anyhow, Dr. Lee from Hong Kong, she is inventor and very profound in terms of ultrasound guided pain procedure. So we would like to do scan from head to butt first. Firstly, we will do in a prone position. Start with the common scan, greater occipital nerve block, and then come to thoracic area. This is a thoracic paravertebral block, and then I will do the sacral scanning for the prone position. And let's see the time. If we can flip the patient, we will do stellate ganglion, and then in the ilioinguinal block, and then sit the patient up to do the shoulder. So let's start with Dr. Lee for the greater occipital nerve block.
So I think you all know the greater occipital nerve is for the cervical occipital headache, and it also is a block for very intractable pain, or for difficult headache, and even for migraine. Is because of the trigeminal convergence of the greater occipital nerve C2 and also lesser C3 at the trigeminal ganglion. So it serves as a block that can help to for chronic intractable headache, and also for intractable migraine, and it also for private occipital neuralgia. So as you see in the anatomy diagram, that the greater occipital nerve actually is come out from at the level of C2, and then also the posterior directions, and then it go cephalic. So with ultrasound, we would like to identify first scanning from above the occiput, and then we would like to scan down, and then we can see the most prominent level of the C2. And then we would like to align our poke horizontally in short axis, and then we will rotate to see the oblique muscles. And as you all know, the nerve is associated with the occipital artery, and so the Doppler signal of the occipital artery is very easy to identify. And once you identify, we will scan up and down to trace the nerve down to the area where it exits between the level of C2-3. And that's what we would like to see. And then it should be, the exit zone should be underneath the oblique, the inferior oblique muscles. So I'm going to show you soon, and then you would like to scan also to see the musculature. Is it the semi-spinal capitis muscles, or is some other muscles fascia that impinging onto the nerve that cause about the anatomy impingement onto the occipital nerve? So without further ado, I'm going to go to this side and then to show you the live scan. So usually the patients will confirm with you the occipital neuralgia, and then you will first, clinically would like to palpate along the course of the occipital nerve, and also we would like to see any tensions with the semispinalis muscles, which one, behind the mastoid process insert into the bone, and then along the lateral course. And then you walk in the front is the posterior scalenus. And then deep inside, then you will actually feel at a lower level of C4-5 than the levator scapular muscles. So you would like to ask the patients, first you palpate and anything outside. And then if you decide for the bulk, and then with the scanning, then we will see this is a high frequency linear pull. And first we would like to put horizontal in a long axis, and then we scan up in the middle, and then you will see. Can you give me more gel? If for the head, because of the hair, you need more gel. Otherwise, you don't want the patient to shave the hair, especially for ladies for this bulk. So make sure you have enough good contact of gel, and then you scan up, you see the occipital. Okay, so up to the now, that is the bone, the skull, and then you scan down, you see the middle, that's the C2, and then you would like to scan along to see the laminar. And you will see the layers of the muscles. The first is the trapezius. And then you would like, at this level, to turn on the color. So it's very important that you need to turn on the color Doppler, and then you will chase to see between, you can see the Doppler signal of the occipital artery. The nerve sometimes, in different people, depends on the echogenicity of the muscles. So you can see this man, that you can see actually his capitis muscles is having some stick of fibrosis and hyperdensity. So that will exactly block some of the signal that you can see with the Doppler. So it's very important, as I told you, is to scan up and down. So you can see that if I cannot see the signal of the Doppler very well, like this, then I will tilt my poke. So this is tilting. Okay? Ultrasound is always an art. A is alignment. Alignment to cut in the short axis you want to see the nerve or the artery. And then if you can align, and you can see the structure, the filias of muscles you want to see, and then you detect, the artery, the occipital artery. And if you cannot see very nicely, then you can scan down. You see actually the nerve. We take off the color first. Sometimes with the color Doppler, the echogenicity is more difficult. So we try to see if we scan up and down, whether we can trace. You can see the nerve and in the middle, the artery will go laterally to the point of the posterior articulating process of C2. So, so as you can see here, then you will see the artery again to more lateral, to going more medial, like this. Okay, so you can see exactly where the point you would like to insert your needle. As you know, the occipital nerve will run quite a long course longitudinally. Okay, so at the same time, sometimes we would like to see exactly where is the impingement or dynamic impingement. So sometimes when I find the target, I'm not very happy immediately to do the block. I will trace up and down along in order to see the best place to put my needle, and at the same time to assess the muscle bulk and also any fascial dynamic impingement. And some also is good is to have dynamic assessment. Can you talk to him to ask him to shrink? You move the shrink in like this and this. So it's harder to do it in a prone positions, but usually I will do it while the patient in sitting position. And this block is not exactly need to do in a prone position. You can ask the patient just lie down, sitting onto a table, and then lying down with a support or support with a pillow. So, or ask him to move a little bit to the right and the left. So actually you can see a little bit dynamic impingement, a dynamic movement along the fascia to see is there any thickened fascia. You see here is like, some stick of hypodense in the tissues, in the muscles, and then you would like exactly know is that the course or, well, the nerve coming out, is there any fascia wobbling, like this. You can see between the two layers of the muscles along the fascia, you can see some frets of the intersegmentations. Can you use the fees? Okay. Yeah. So you can see this is the trapezius muscles, and along the superficial layer of the deep fascia, superficial fascia and the deep fascia, you can see there's some frets of, actually it's the same, it's the capitis muscles, but there's some frets of intersegments fascias, the frets, allow the movement and the guiding of the muscles. And most of the time the patient, if they have some minor tremor or, the muscle spasm, and if this is kicked with a wobbling between the fascias, and that's where the nerve, the peripheral nerve being stimulated. So that's how we usually, apart from doing the nerve ball, we also would like to ask the patient. You can see, if you scan down, actually it's the same muscles, isn't it? You see it. And then as you scan up, then you detect this kind of frets. This is normal frets. This is not a scar or anything. But if the patient's having some period spring or strings, and then you notice that this kind of regional contractions in the muscles will leading to the irritations onto the nerve. And so this is something very funny. I show you. Usually with this kind of a muscle spasm, if you walk, just manual therapy. I want to show you why the patient like massage, okay? And I love Thai massage as well. And with rubbing, you can see the layers will loosen up. Can you see it? And then if you ask the patient move, ask him to chin in and move a little bit of the neck. Yeah. And then you can see how much he can recruit the muscles and how well we can recruit the muscles. And I usually will show this to the patient while he in sitting positions and ask him to do more chin in movement, and such that he know that he can recruit the muscle back and train back the muscles. So it's not only the block, but associate after the block what he should do with the rehabilitation exercise. And that's something very important. And then on the other hand, we can also see longitudinally. That's the long axis. So you can see the C2 and then the C3. And then we can also see how the deep layers of the muscles are locking onto different facet joint. And usually, he has a very nice muscle bulk. But for a lot of patients, I scan on myself, then you can see the deep layers of the muscles, semi-spinalis muscles, usually will lock up the facet. And that's the reason people have sarcogenic headache and this kind of occipital neuralgia. So, and we can also see yes, sorry. The facet joint. Sorry, there's no clip, right? This is the facet joint. Okay? And for the third occipital nerve, it's usually here. You can see as hyperdense area. So we would like, usually we block the greater occipital nerve, and sometimes we also would like to block the third occipital nerve as well. And that's also very good. I try to use this as a mic. So I want to show you on myself.
Too many equipments, right?
I think it would be a great idea if we teach, and then the ultrasound also can serve as a. So I just want to show you different anatomy, okay? So because I know that I have a very tight fibrotic neck muscles, so that's just to let you know on if on movement on sitting position, you see protrude the head like this, and then we chin. Okay, so you can see I can recruit the middle capitis muscles as we do the chin in posture. And then this and this. So this is a good exercise to teach the patient together with the greater occipital nerve block. Thank you very much.
Okay, thank you, Dr. Lee. So we're going to move to the next block. It is thoracic paravertebral. And just a quick question about the greater occipital nerve block there. So if the patient got a good response after the greater occipital nerve block, it doesn't mean that patient have a occipital neuralgia, right?
Yes, it's not only work for occipital neuralgia. Actually, it works for, as I said, sarcogenic headache, and also in migraine as well. And some of the patients, they have some atypical facial pain because of the innervations of, it blocks the afferent signal, the peripheral sensitizations to the convergence trigeminal neuralgia. I remember there's an IASP chapter that have very good summaries about the sarcogenic headache and the trigeminal connections. Yeah. Thank you.
Thank you. Yeah, so a lot of people believe that the greater occipital neuralgia way overdiagnosed because people tend to getting better after the greater occipital nerve block, and actually it's so non-specific though. Even patient got migraine or any kind of headache, gonna getting better with this kind of block. We're gonna move to the next one.
For the headache. If patient having very severe headache and refractory to other oral medicines, actually this is always the block that we can consider to stop the headache. Even for trigeminal neuralgia, it can stop the pain. It like work for most of the head and neck pain.
Yeah. That is the trigeminal cervical complex, right? Yes. Yeah. Okay, let's move to the next section. I'm Donald from Taiwan. And I know everyone is pretty tired, so I will try to make it clear and simpler. And this is very important technique to do no matter either acute pain or chronic pain. So let's start with the anatomy. When it comes to the paravertebral space, the lateral border, actually there's no lateral border. It ends up with the intercostal space. And the medial border is the vertebral body disc or the foramen. And the posterior and anterior is that posterior is the tip and ribs. And another important structure is that the superior costal transverse ligament that is formed by the inferior rib and the above transverse process. Then the ligament connects these two structures. And the anterior border in the upper thoracic area is parietal pleura, and the lower in T11 and T12 is diaphragm. And the superior inferior border is partially separated by rib and transverse process, but actually the upper and lower transverse process is continuous in the anterior medial corner. So the indication is very important. Sorry. This session actually is a very technical oriented session, but I have to say diagnosis is the most important one. So if the diagnosis is wrong, any technique will fail. So the indication includes surgical procedure like breast surgery, thoracic surgery, or upper abdominal surgeries, and appendectomy, hernia repair. In acute pain, you can do it on patients with rib fracture or any abdominal wall trauma. In chronic pain, you can do it for any neuropathic pain patients like complex regional pain syndrome or herpes zoster or PHN. So the anatomy, there are several approaches for paravertebral space. As I know, at least 7 or 8. But today I will show my personal favorite one, that is the transverse scan. As you know, in ultrasound scan, the bone is the safest structure, and you can be very confident with the bony structures because they're very hyperechoic. So the first step we can see around here, that is the costal transverse joint. The rib connect with the transverse process, and there is no space below these two structures because the acoustic shadow. The first step is to find the leads, and then move the probe slightly down, slightly caudally. The rib will gone. So now there's only transverse process, and this is pleura. In the middle is the thoracic paravertebral space. This is the most workshop or textbook to teach students or doctors to practice thoracic paravertebral space. But if you move the probe further caudally, the transverse process gone as well. So there is inferior articular process of the thoracic vertebral body. So there is no transverse process. You can advance your needle directly, very ventrally, very medially, to the close to the intervertebral foramen. This is my personally most preferred technique. I like to do it here. So if the thoracic paravertebral space block is too dangerous, or you have to be very brave to do this, you can do another technique that is simpler, like intercostal nerve block. The key points is where should we put the probe? That is about 6 to 8 centimeters from the midline. Why? You can see the anatomy. The intercostal nerve, which is the ventral ramus of the spinal nerve, it will separate to form the lateral cutaneous nerve and anterior cutaneous nerve in its way. So don't do it too laterally or too anteriorly, because these two nerves have separated and you will block only one nerve. So if you do it at about 6 to 8 centimeters from midline, probably this nerve has not separated, so you can get two in one shot, get to nerve in one shot. Another reason is that in this place, the space of rib is wider than other place, so it's easier for you to advance the needle. So this is our ultrasound. This is a rib, and there's a intercostal muscles. And another novel technique is the erector spinal plane block. This technique is the most easy and most safest techniques around here. The technique is to find the transfer process about the mid-thoracic level, and just duck your needle on transfer process in which level you like, and give some small bolus to verify your plan is correct, then inject the injected 20 or 30 milliliters or something like that. Yeah. So let's move to the yeah.
Which one do you want? The linear or
Curve.
That's great.
So now I'm scanning the left side parabolic space, and in the left side is the lateral side, and the right side is the medial. First, we can get the spinous process that is most easy structures for us, and then move laterally to find the rib. Here is the rib. Pointer. Okay. Thank you. Okay, find the rib and the transverse process. Later, move it down slightly. Don't move too much. Slightly, and the rib is gone. So the very bright line that is pleura, you can ask the patient to take a deep breath and yeah, okay. Probably in some patients you can see the very significant movement of the pleura and the lung. And here is the thoracic transverse process. Okay. In here you can do the thoracic parabolic space block. Can you push? Yes, just a little bit over the transfer process, but don't advance too much. And my personal preferred location is here. This is the inferior articular process, and where we place needle is the angle of the acoustic shadow and the pleura. So be careful, don't pound through the pleura, or you will get a pneumothorax patient. Later, when where's the intercostal nerve, we can begin with the erector spinal block. First, we begin at the midline. This is the thoracic facet joint, and move slightly laterally. You can see this is the junction of transverse process and the rib. I have a small tip for you. Transverse process is more like a square, but the rib is more like a circle. So it's easy to distinguish these two structures. So here is our junction of transverse process and the rib. So this is the transverse process. In erectile spinal plane block, you can just duck the needle on the top of the transverse process and try to separate the erectile spinal muscle and transverse process. Later, we move the probe laterally. This is the intercostal space, and I have to say, this area is very highly vascular. So the systemic absorption of local anesthetics is very fast. So be careful of local anesthetic systemic toxicity, and always turn on the color Doppler to check out if you advance your needle into the vessels. Yeah, linear probe will be better. And the best location is about 6 to 8 centimeters from the midline. Okay, let's move to the next section.
And what is your most common indication to do the paravertebral block in chronic pain patients that you, in your practice?
Actually, it's a postherpetic neuralgia. Postherpetic neuralgia is my commonest indication in chronic pain practice. But sometimes the analgesic effect is not so durable, so probably we have to repeat many times, and the patient might not get pain-free, but after repetition of the injections, the baseline pain will decrease after your treatment.
Okay, let's move to the next one. Now we move to the butt, and actually, as a privilege of the organizer, I just pick up the block that I like the most, and I am particularly interested in buttock area. I mean, professionally. Because this is an interesting area, though. There is no owner about this. If the patient have low back pain, there's going to be orthopedist, right, or neurosurgeon. But the buttock pain is still a mysterious, and a lot of structure in this area can cause pain. So if you just wonder what the pain in the butt look like, just look at our face. This is when we take our pain clinic photo together. So special thanks for this presentation. Would like to thank Philip McClare, Philip Pengs, and Karina Lee also. Thank you for being here. I was unprepared, and someone told me I have to give a presentation of this workshop in Philippines in 2017, and for very great help from them. I got a slide, and I can go on with that presentation, and it is very, very helpful. So there's gonna be a lot of structure in this area, but just gonna focus on the two most common injections that I do the most in my clinic. The first one is the sacroiliac joint, and the second one is the piriformis injection. I just gonna bring you to the tour to the sonographic landmark in this area. We're just gonna go it like a clockwise rotation, and each landmark gonna give you some clue and probably some benefit or landmark to do the block also. We start with the sacrohiatus, lower part of the sacroiliac joint, upper part of the sacroiliac joint or PSIS, and then move down to the lateral side to the piriformis muscle and come to the end at the ischial spine. So let's go one by one. Start with the first one though. The easiest one is sacrohiatus. So you can palpate the midline and try to find the sacral area. You can start from the coccyx. It's going to be the flat white line. It's the coccyx, and you just scan it up until you see this one. This is the happy frog. This is the frog eye, and this is the sacral hiatus. You can see the sacral cornu here, the sacral coccygeal ligament, and this is the sacral hiatus. You can use it as a landmark to do the caudal epidural steroid injection, but the thing is, you should not use just ultrasound alone, because ASRA guidelines don't recommend that. Once the needle passes the outer cortex, you cannot see the needle, so you should have a fluoroscopy to guide as well. beside the ultrasound. But that is not the point. The point is we just want to see the sacral hiatus, and we want to focus on the lateral border of the sacrum, because of that if we just focus on lateral border of the sacrum and follow it upward, it's gonna hit the ilium, right? And the gap between sacrum and ilium is sacroiliac joint is easy, right? So we just follow them though, and then we see the gap between two bones is going to be the sacroiliac joint. Another way to make sure that it's not just only our imagination is to make sure that they have a correlation anatomy also. If you cut at this level, you can see the bump up and down of the heel and some valley or hole here. It starts with the medial sacral crest and then go down to the sacral foramen, either S1, 2, or 3. And then it's going to bump up again to be the lateral sacral crest and then sacroiliac joint. With the sonographic image, it's going to be like this: the medial sacral crest, the sacral foramen, lateral sacral crest, and SI joint. And this is where we do the radio frequency ablation. So for the sacroiliac joint dysfunction, it's just going to be very brief review. We don't have a lot of time. But the thing is, it is important because of its gold standard of diagnosis of SI joint dysfunction. There's some controversy about upper part or lower part. Lower part is more popular and have a better evidence. Periarticular versus intraarticular. I think people now more believe in periarticular have a better evidence also. And there's a pro and con of ultrasound guided versus fluoroscopic guided. Ultrasound guided can do that. The bedside is easy, radiation exposure free. But the thing is, you can see the arteriogram, you can see the intravascular injection, and it's tend to be periarticular more than intraarticular. So for the next move, we already passed to landmark already, right? This one, the sacral hiatus, lower part of sacroiliac joint. When you go up and follow that relationship, you're going to see the upper part of the sacroiliac joint, and you're going to see the big bone here. This is the PSIS, or posterior superior iliac spine. If you want to do the upper part of the sacroiliac joint dysfunction, you can do it here because it's still considered a sacroiliac joint, right? It's junction between sacrum and ilium. But the thing is, a lot of people believe that this is just bone, it's not joint. So less and less people do injection in the upper part right now. But the thing is, I just want you to focus on this thing though. This is ilium, this is continuous bone. Look at this. When you scan down, when it's gone, it's going to be greater ascitic foramen. And this is some important things come out from the greater ascitic foramen. There are just three things coming out from the greater ascitic foramen. It is the piriformis muscle, sciatic nerve, and pudendal nerve and artery. Actually, four things. But anyhow, we look at this one. We focus on the piriformis muscle. It is come out from the foramen and attached to the greater trochanter. So Dr. Maburo Kodatos already mentioned about piriformis muscle this morning already, so I'm not just going to repeat the talk. But the thing is, someone still don't believe that it exists, and someone still believe that it's underdiagnosed also. So it's still like debating about that. When you do a scan, look at the greater sciatic foramen, the muscle that come out. And because of the action is weak external rotator, so you can do like an external and internal rotation of the hip, of the femur. So you can see the movement, and the wheel is not working here. Okay, and sometimes you can see a vessel, though, like a superior gluteal vessel and inferior gluteal vessel. So it's a lot of vessel in this area. Be careful and use the Doppler, use the color to detect the vessel. And then another important structure is the sciatic nerve in this area also. If you're too close or use too concentrate local anesthesia after the sacroiliac joint injection, piriformis injection, patient can have numbness for a day. And then last but not least, if you can remember that when we found the greater sciatic foramen, the bone underneath is no longer ilium anymore, it's ischium. And we focus at the ischial spine. The ischial spine is the part of the ischium bone longest. So you just scan until this bone get longest one. There are going to be a couple of phenomenon here. Piriformis will be gone at this level, and at the tip you can see the pudendal nerve and pudendal vessel, and this is where you're going to do the pudendal nerve block. So suggested reading by Philip Peng. This is a very, very good book. It is an ebook, and he also reviewed in APM also. I wrote one chapter when I was at the Brigham with Jason Young and Arsia Walowska, which is pretty good one because I wrote it. And then and then just gonna tell you about a little story. I met Philip Peng and Kalina Lee and a bunch of founder of the regional anesthesia group. He told me to take this exam because I did regional anesthesia fellow and pain fellow, and this is kind of like a good for someone who loves ultrasound also, the certificate of the pain intervention. And then I flew to New York last year. I met two more people from Taiwan. One is this one, Kevin Chang. He's a celebrity. And then me, and this is Donald Tang. So just three of us that got the certificate for the Astra. So that's why I invited him here. So why don't we go to hit the butt? Then, thank you. Okay, so usually for the sacroiliac joint, for the thin guy like this, we can use the just linear probe. That is fine. But because of it's just gonna do clockwise rotation and just gonna look at the piriformis muscle, which is pretty deep. So we just use this one, the curvilinear probe. So first of all, before you put the probe in, palpate first to make sure that what you expect to see. So now you palpate on the bone. You expect that when you put the ultrasound probe in, you're gonna see the bone. And then orientate the probe. So now left is left and right is right. And you can scan up and down and try to find the happy frog. That look like I found one here. This is a happy frog. If I go down, I just gonna see only white thing, right? The white single plate there, that is the coccyx. So turn back to happy frog. If I want to do the sacroiliac joint injection on the right side, I just try to focus on the lateral border of the sacrum, which is probably this one, and it's just gonna scan up until it hit another bone here. So you can see this gap. I just guess that this probably sacroiliac joint, but I'm not 100% sure because the way to confirm that, you should see the structure that I mentioned, medial sacral crest, right? Sacral foramen, lateral sacral crest, and then sacroiliac joint. So just move upward until you see that relationship. Yep, I think I see something here. And this is the sacral foramen for sure. Probably S2. And then you can see the gap on the right side of that. Yep. That is sacroiliac joint. You can tilt up and down a little bit. The gap is not going to be that wide, or don't imagine that it's going to be like a big hole. It's just going to be like a small gap. And then you can keep scanning up. You can see another hole here. Another gap here also. I guess this is probably S1, right? And then you can see on the right side, the ilium bone getting bigger and bigger, and it's gonna turn to be the PSIS soon. So here is this PSIS already. And if you see the junction here, probably you can do like a upper part of the SI joint injection in this area, but the thing is, I don't do the injection in the upper part of the SI joint. And now we are on the heel. We already passed two landmarks, right? The first one is the sacral hiatus, lower part of SI joint, and this is the PSIS. Now we go lateral, and we can see the heel on the right side, right? The heel. This is the ilium bone. We scan down until the heel is gone. Yep, look like it's got the break here. The thing is, there is some tiny movement here. It's like a secret because of the hole is not like this. It's tilt a little bit. So if you want to dig in the hole, you have to move the probe lateral and turn a little bit medial. And then can we go like a little deeper? And then tilt to the direction of the piriformis muscle. And now we can see the greater sciatic foramen. You can see the bone on the right lower corner. That is the ischium bone. And if you want to confirm if this is the piriformis muscle, you can do like an external and internal rotation of the hip. Yep, and this is piriformis muscle. You can see that it's not like an equal thickness for the whole muscle. Usually the middle part, especially the middle 1/3, is a muscular part, and people tend to have the problem in this area more than the lateral part. And keep in mind that the bone on the right lower corner, that is the ischium bone. You're gonna look for the ischium spine. So the ischium spine is the longest one. So you just scan it down, 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 until it's longest. Now it's pretty long. If you scan it down a little bit more, it's kind of gone. So now you look at the tips of the ischium spine, you're gonna see the pudendal nerve and pudendal artery. And that is where you do the pudendal injection. That's it. Okay.
I want to show you, because usually, I just add a little bit. That's how we see the sacral foramen. So if high up, you see the alpha S1, and the sacral bone is like dinosaur. It's a continuous wavy line. So that's how we count the S1, S2 foramen. So that's the S1 and the S2. And then S3. So as we all know, we usually block the SI joint at S2, S3 level. That's usually the area. And if we aim for radio frequency ablations, so it's very important that we try to avoid the sacral foramen level. So we would like to move a little bit more lateral until we cannot see the sacral foramen. And then we put the needle for the RF. So that's a combination use of ultrasound together with fluoroscopic ablative therapy technique, apart from the diagnostic block of the SI joint. Yeah, that's something additional. Yeah.
Great. Thank you, though, because a lot of time with the fluoroscopy, sometimes it's quite difficult for me to identify the lateral sacral crest, and this is very useful. Okay. Let's move to the next one. I think we have like about another 15 minutes. Let's see how it's end.
So probably. Okay, let's move to the next one. The next one is the static ganglion block. Actually, to be honest, in Taiwan, we have some senior doctors will say the static ganglion block cures every disease, but actually it is not. But it is very useful. So let's see the anatomy first. Actually, we inject at the C6 or C7 level, but literally this this ganglion actually is around the C7 to T1 or T2 level. So where we inject is actually not the stellate ganglion. We depends on the spread of injectate in the interfacial plane. So later we will demonstrate how to identify the zigzag level, which is corresponding to the level of cricoid by landmark. So an indication is so many indications. The first type is the vascular, like critical vascular disease or renal phenomenon, renal disease, renal syndrome. For chronic pain management, complex regional pain syndrome or post-herpetic neuralgia or any other neuropathic pain syndromes, you can just give it a try because this technique is relatively low risk. And for other neuropathic pains from head, neck, or upper thorax, upper extremity, you can always give it a try to do stellate ganglion block. And the other two is some distinct applications. That is, the first one is the postmenopausal syndrome. The second one is the post-traumatic stress disorder. I have to say a story. Several months ago, a patient come to me for low back pain. After several sessions, he told me he have to register for visiting me because he stays in the psychiatric nursing home. But I found he is quite normal. So I asked him, why do you have to stay in the psychiatric nursing home? He told me that he has some threatened from someone because of the dispute of his house several years ago. So after that, sometimes he have some delusion or hallucination, or something like that. So he was recruited into the psychiatric nursing home, and I give it a try to do the stellate ganglion block for him. And in the next session, he told me he feels much better. So I think that the post-traumatic stress disorder is it is a very feasible treatment for this disorder. And for postmenopausal syndrome and PTSD, there are randomized control trials. So you can try after this symposium. So the anatomy is not so difficult, but I have to show you some pitfalls. The first one is the inferior thyroid artery. It's very common to see it at the C6 level. That is a branch of thyroid cervical trunk. So avoid intravascular injection because this is the cervical area. So the systemic concentration will be much higher than other places around in the body. The next one is when you do the left side stellate ganglion block, be careful of the esophagus, because when you puncture or cause any injury to esophagus, the complication will be very severe, like mediastinitis or deep neck infection. So if you do the left side stellate ganglion block, always scan the esophagus. So let's move to the real scan.
Why don't you talk about to block and then scan in the same time?
Okay, the next one is the ilioinguinal and iliohypogastric nerve. To be honest, the indication for this two nerve injection is not, I didn't do it very often, so I try to explain it as simple as possible. That is from the L1 and with some contribution from T12. And these two nerves often runs parallelly. So, and the higher one, the cranial one is the iliohypogastric nerve, and the caudal one is the ilioinguinal nerve. Yeah, and after they leave the psoas major muscle, they will penetrate the transverse abdominis muscle in some place and goes into the plane between the internal oblique muscle and transverse abdominis muscle. that is the same plane with the TAP block. Actually, they are in the same plane. And how to scan it? So the first step is to place the probe just at the level of the line between the subcostal area and the iliac crest. Don't move it too medially because the nerve will gone and you will find the nerves. You will not find the nerves. So place the probe in the midway between the iliac crest and the 12th rib. And where we place the probe is here. This is the ASIs, and this is the ASIs here, and iliac crest is here. Actually, this picture, we should move this mark around here. That will be better. And if you move the transducer more medially, there will be only one nerve in the space, or even no nerves in the space, because these two nerves will finally become to be a cutaneous nerve along inguinal area or medial thigh or hypogastric area. Okay, let's move to the scan. In my practice, I always count the level of the spinal nerve root. So if you cannot find the nerve, you can go to the muscle anterior scalene and middle scalene, which is called the interscalene block. The anesthesiologists do. So here is the brachial plexus in the middle of the screen. And you can move the probe up and down, try to follow the nerves, go back to the vertebral column. So we move upward. This is probably, sorry, wait a moment. Okay, this is the C7. Why? Because it only has the posterior tubercle, but no anterior tubercle. So this one is the C7. And later we move the probe upward. You can see this one. This is the C6. Why? Because the anterior tubercle is very big, which is called the Chassaigne tubercle in French. Probably in French, yeah. I'm not sure. I'm also not sure whether my pronunciation is correct or not. Maybe we can ask the Professor Philippe. Chassaignac. Chassaignac. Okay. And the next one, this is a C5. Okay, this is C5. We can see C5. The anterior tubercle and the posterior tubercle is quite equal. The size is similar. So this is C5. Move downward. You can see this is C6 here. This one is C6. Okay, when you arrive C6 level, you can move your probe more medially, and this is the left side. So I have to show you the esophagus. Where is the esophagus? Here. Can you ask him to swallow? Swallow. Okay, you can see that the esophagus is moving. This is the esophagus, and the muscle lateral to the esophagus is our target, which is the longest colon muscle. So if you advance your needle too much, you may hit your esophagus, and the patient probably will get infected. And the target plane is the interfascial plane between the internal carotid artery and the longest colli muscle, which is the prevertebral fascia. And the volume is probably 5 to 10 milliliter and 1% xylocaine. That is enough. So, this is the longest, yeah, no. This is the longest colli muscle. And this is the prevertebral fascia. This is the internal carotid artery. Esophagus is somewhere along this direction, so don't advance too much. And your injectate in this plane and try to separate the muscle and the vessel. That will work very well. And someone says that to do an intramuscular injection will be safer, but I don't have that experience. I just share with you that someone says like this. This side. This side.
This one, right? So we're going to move to the ilioinguinal block.
The first, to palpate the iliac crest and the 12th rib, and place your probe in the midway of these two structures. In the left side is the cranial part, and right side is the caudal. So move the probe more slightly medially. Actually, if you are in just the mid-axillary line, it is the place where we do the TAP block, and we move it slightly medially. Okay, freeze here. Here are two nerves. This one is the caudal one, which is the ilioinguinal nerve, and this one is the cranial one, which is the iliohypogastric nerve. And to do the block, actually, it is not possible to separate or to block only one nerve, because these two nerves runs very close and in the same interfascial plane. So if you inject in the fascial plane of the internal oblique muscle and transverse of the omnis muscle, these two nerves will both get involved in one injection. So what is the indication for me? I have met some patients like they received the surgery for hernia repair, or another patient is for debris of the abscess, retroperineal abscess. So here he has a very large incision here. So if your patient has any trauma or injury along the location, along the track of this nerve, you can try a diagnostic block or even therapeutic block for these two nerves. And the symptom probably will be the iliohypogastric area pain, or pain over the ilioinguinal area, or the medial side of upper thigh.
Yep, thank you. And Kalina, do you want to like a quick scan for the shoulder? Actually, we scheduled for like a 7 scan, but look like we ran out of time. So probably Dr. Lee gonna show us just the quick scan for the shoulder. นั่งแล้วกันครับด้านหลังเข้าใจว่าน่าจะไปแต่จริงๆมาด้านนี้ดีกว่าเขาจะได้สแกนได้
Yeah. So the shoulder actually is a lot difficult, and so we first need to know the shoulder anatomy. So it's very important we distinguish exactly if the patient complains of shoulder pain. The first thing is that whether this is really a shoulder pain or is a refer C4-5 radicular pain. That's something very important. So if it's a radicular pain, as you all know, they will have swelling sign. So first you ask the patient, to turn the neck to the side, left side, right side, just move the neck whether there is a refer pain. If that's the case, then you better check the cervical nerve root exit zone, or take an X-ray of the cervical spine to see if it is possible to prolapse this cervical spine, or osteoarthritis or foraminal narrowing irritations onto the C4-5 nerve root. Because I have seen a lot of time. I even just recently I've killed a patient, I treat the patients that he come from Australia. He have both shoulder operation done and one arthroplasty, change the femoral head for the surgeries, because he has been seen by sports surgeons. Then he think he have the shoulder pain, and the surgeons find some degenerative changes in the shoulder. So he have, shoulder arthroscopy, shoulder arthroplasty, hemiarthroplasty, both sides of the shoulder being treated. And then at the end, I found that actually he is cervical problem. So I successfully tell off all his potent opioid. he come with potent opioid. And so this is something I think is the history. The history taking physical exam is still most important, not only to learn how to scan the ultrasound, but also correlated to the history and the physical exam. And if shoulder, pure musculoskeletal nociceptive pain, it should be localized, and it should be dynamic, and it shouldn't be having pain at night time. Cervical genic problem or cervical pain, patient will complain of more pain while they're lying down on a pillow. I think that's a very important part of the history. And so, and usually, muscles, shoulder pain is dynamic. Whenever they move the joint. So, this is shoulder joint movement. Shoulder joint movement, fascias. You have to know different muscles movement in order to diagnose it. So the most important shoulder rotator cuff, supraspinatus muscle, infraspinatus muscle, teres muscle. Anteriorly, you would like to see, the AC joint, acromion, coracoid process, and the short head and the long head of the biceps, subscapularis. So the bicep for the short, long, and short axis. As I said before, if you detect, for any regeneration therapy, first you would like to see any, at the biceptal groove, any effusions, any increased Doppler signal, and you notice any bursa, bursa inflammations, bursa thickening of the fascias, and also, any tendinopathy. As you can detect, any peritendon effusions. So you need to scan the short axis and the long axis, and then you scan from above and then scan down below. This is actually the PDF file from ESSR, the European Society of the Musculoskeletal Radiology, ESSR, and they have excess of MSK ultrasound protocols. So actually, so ESSR ultrasound protocols. So it's you can see all the protocols and then to show you. So it's also important that you trying to ask the patient to do dynamic movement in order to scan the musculoskeletal. So for the biceps, you can scan on a horizontal line and also along the longitudinal. Then you can also longitudinal, you can more lateral, the short head and the long head of the biceps. So if there's any abnormal, then you will see increase in the color Doppler signal. And you will also like to see it, whether it's peritendon or it is actually with the bursa. So it's very important, you need a dynamic scan in order to know the guiding of the tendon over a bursa. And also this is the same for the supraspinatus. We would like to see the supraspinatus attachment to the humeral head, and also along, you know, from the anterior to the posterior component. And most of the time, people having supraspinatus tear is at the myotendinous junction. So you need also a dynamic diagnostic scan in order to see whether it's the tear problem or is actually is the subacromial bursa or bursitis issues. So this is to show you this is a punch. Hypodense lesions, that is actually the supraspinatus partial tear, which you can also sometimes you detect whether it's acute or it's a chronic. If it's more acute, you can see a rim of hematoma or a rim of effusions. But if you can see it as like this case, is more a chronic problem, and also you can notice maybe some patchy hypodensity. And maybe some people also have thickened fascia or calcification, then you know this is more tendinopathy and acute or chronic problem. This is to show you different rotator cuff pain pattern. And usually for musculoskeletal pain, the nociceptive pain, one is dynamic, is increased pain with movement. Two is more dull agging if not moving. And if it is moving, it is sharp. It's lanciating pain, it's fasciitis pain, but it's not pins and needle. It's not associated with numbness. So that is to distinguish from the radicular cervical cause of the pain. So, and this is to show you the subdeltoid subacromial bursa, and this is like healthy, it's like a rim of bursa, but it is if it's bursitis, then you can see a filling up area of hypodensity. And same, we also do it with a dynamic scan. Ask the patients, you know, if they have painful arch, then we will scan the painful arch to see the humeral head notch getting back into the subacromial region. And we can also scan on, you know, posterior shoulder, and sometimes we can see there's entrapment of the dorsal-scapular nerve. Dorsal-scapular nerve is a motor nerve. Okay, it's a motor nerve. It's not a sensory nerve. I start to teach this entrapment a few years ago in MSK USPM and some other Asia meeting. But you have to know that it is a motor nerve. But with its impingement, it will cause warm body muscle weakness and atrophy. And that's why the patient have associated pain with this impingement. It's because of the interscapular muscles imbalance. So it's the whole rotator cuff imbalance. So that's the cause leading to, you know, the anterior displacement of the shoulder and cause other impingement. Always with musculoskeletal pain, if there's one pain associated with one tendon of muscles, it's not a single problem. It will associate with other biomechanical movement, and it changed the whole joint dynamic. And this is something that I would like to let you know. If you just treat one single pathology in one tendon, just like the shoulder joint and the hip joint is the same. One muscles or tendon having the problem, it will leading to all other associate rotators having similar problem because the disuse and fear avoidance. So it's very important if you do any therapy or treatment, you have to teach the patient to do some simple toning or coordination exercise. Like, you know, for the shoulder, it's like painting a wall, 1 o'clock, 2 o'clock, 3 o'clock movement, like Tai Chi or some simple yoga. So I'm going to show you the dynamic scan of shoulder.
Sure.
Let's take a seat. Maybe this side.
This one.
This one.
Like a little bit, please.
Okay. Maybe this pull a bit back. I need the shoulder. I need the shoulder. Shoulder. This side. This shoulder. This side. This one. A bit more. Stand up. Okay. So there will be a quick scan because time is running out. Take off the sleeves. Okay. Cover like this. Okay. So it's first important to ask the patients, to move. You have to know this is the actions of subscapularis, okay? And this is called cast sign. I want to use that. This is the cast sign, like a model, okay? This front and back, this is the action of supraspinatus, okay? And this is painful arch, the deltoid movement. And then you need to make sure that the patient doesn't have a lot of pain while they're doing that. Is that the light shine? Okay, we move a bit back. Okay, good. So first, ask them the movement, ask them to move. And then usually, what I would like to know is that when they elevate the shoulder, then see any over movement of trapezius. There's a lot of people, they recruit the most superficial and big muscles is the trapezius. They will shrink up their shoulders like this and overuse the scalenus and the sternocleidomastoid. And that accounts for a lot of patients' pain of, the warm posture because they use the tablet and the phone. And so that acquire a warm posture. So shoulder movement purely is like this or like this. Or maybe a little bit rotational. I always teach patients like Pei Majak in Hong Kong, Pei Majak, and also swim, swim. And underarm activity. I will ask them to move some underarm circular motions in order to recruit the shoulder, especially for capsulitis or frozen shoulder people. You cannot ask them to do like this. It's too much. And don't do the fear band exercise at the beginning. Just do rotational recruitment. It's just like the hip. The hip piriformis problem, you also need to treat, to recruit other gluteal medius, minimus muscle. So that's the same concept. Okay. Joe.
Yes.
The easiest thing is to see the joint. Okay, so you can see in the middle, this is the acromial clavicular joint, AC joint. So normally, unless people have trauma, they seldom have real effusions or dislocation here. But the bikers, a lot of time bikers, collisions, and maybe road traffic accidents, then if they have pain there, then you can scan on it and see there's avulsions, displacement, and sometimes with pain, you also would like to see the color, Doppler signal, anything around that. Okay, so and another you would like to see and very easy is the acromion, and then see whether any subacromial impingement. Okay, so I can see that actually the bursa is within a normal. The arrow. Okay, so you can see, actually this is the rim of the bursa, and this is the deltoid, and this is the bone. Okay, so this is the acromion. So I'm going to ask him to move, and then you will see any dynamic impingement. Okay, try to move like this. Then you can see, slowly. So because he's a young guy. Yeah, okay. Slowly elevate up. Okay, so if anyone have a painful arch or they have any subacromial impingement up to this point, then you will see the thickening at around navel. Yes. Then you will see the thickening around this area or with the bursitis or a period, repetitive bursitis calcifications thickening, then the middle-aged lady or man will have pain up to that point. Okay, so you see he is very, very good and he didn't have any problem. It's also good to examine, this is to show you the tendon and it's fibula. The pattern, the fibular alignment, and then you can see, the fascias and everything, the alignment is very nice. Okay, then we scan to the anterior shoulders, okay? So horizontal, transverse pain. This is the biceptal groove. And you can see nicely the bicep tendon. Okay, there's no peritendon effusions. And at this point, then you can ask him, you want to see the rotator cuff interval, then you can ask him like, beggar, okay? And then to move in, adduct, and then out, okay? So you can ask him move like this, and then you can see any entrapment and anything abnormal kicking along the fascia. So at the same time, you can see scan up and down a little bit. Then you can see very nicely. Okay, when he out a bit more and more, this is subscapularis. Okay, so you can see along the whole plane of the subscapularis tendon to the insertion site is very beautiful, okay? And the attachment site, you see any irregularity or any tendinopathy, and then that's nothing, okay? Subscapularis is nice. And then we also, okay, you just rest here, rest here, okay, rest here. And then we would like to scan on the longitudinal component of the bicep tendon, okay? So we can scan on the lateral, the short head. So slowly. And scan done. Okay? So you can see nicely the tendon. So if people having and this is a thin bursa, I don't regard this as having any pathologies. Okay, a little bit rim of bursa, which show as hypodensity. Okay, this is the bursa, very beautiful. Okay, and the attachment in people having tendinopathy, you will see there is a patchy echogenicity along the tendon, and you couldn't see so nice filament layers, and this is very beautiful. Okay, so we want him to do the model, the cast sign. So at the back, then we see the supraspinatus. Okay, at the top, this is the trapezius. Okay, and the supraspinatus. So you can see the supraspinatus from the posterior, and this is the myotendinous junction. A lot of people, they may have pain at this junction, myotendinous junction, when they overwork, and repeated sprain and strength. So actually this is a very big muscles, and also a thick fascia. It actually from here to here, you can scan the whole bulk of the supraspinatus and also the myotendinous junction. So some people, if they have pain or having a good muscle bulk like him, so you would like to scan like this, okay? From the end, so to a little bit posterior, and relax. Don't shrink up the shoulder. You see, he tends to shrink up. Okay, relax, drop down, okay? A lot of people is like this, okay? So we try to scan, to try to see the most you can see here. And then when you detect anything, or you ask him to move, you know, I guess my force, in, forward, forward. No, cast side, and then here, forward first, yes, okay. As he moves forward, then you are able to see the attachment of it to the bone, okay. So here you can see that actually, slowly, more to, yes. So we try to scan to the anterior. And then when he moves like this, and then you can see it go back to the biceptal groove with the bicep. So that's the rotator cuff interval. So you would like to see on his moving like this and backward, and see is there any stickiness or thickening along the whole supraspinatus tendon. So can you see? This is exactly the point where it insertion to the humerus. And freeze it. So I can detect a little bit pathologies. Is here. There's a little bit hyperdensity on its attachment to the bone. So you can say if there's no effusions, then there's tendinopathy, just mild tendinopathy features. Thank you very much.
Great. Look like we just finished the multi-nation session. So thank you very much, Dr. Lee and Dr. Tang. So do you have any question for this session? Probably just like one quick question because it's quite late already. Wait. Okay. If there's no session, we will have more detail about each scan on the workshop on Wednesday. It's already fully booked, like 3 times booked already. So for the one who already have ticket, just keep your ticket because it's so valuable at this point. But if there's no further question, I just would like to pass it back to the Master of Ceremony. Thank you.
And before ending the session today, I would like to invite Ajahn James to give the shirt for the lucky person, 3 person. I wish this pen forum today will offer the knowledge and information for you to apply in the clinical pain medicine.
Oh, okay. Look like this is kind of fun. So the award is our T-shirt for the 30-year ceremony. When it says stop, it's gonna be stop, and the first one gonna be stop. Niruji Sang Som Suan. Okay, congratulations. Good. Okay, that's fine. We move for the second one. Okay. Okay, and stop. The second one is Dr. Aruna Gun Priyapan. Okay. Oh, just sit next to each other. Look like Thammasat is so lucky today. And the third one, go for stop. Okay. We have a delegate from Colombia, right? Oh, Cambodia, sorry. Okay. Congratulations and hope all of you have a good evening. Remember that the MC will announce about the group photo. Oh.
And after ending the program today, I would like to invite you all, include the speaker and our participants, to take a group photo shot at the Sala Thai on the Chao Phraya Terrace. ค่ะเดี๋ยวมีถ่ายรูปรวมนะคะที่ตรงศาลาไทยอะค่ะเลยตรง SAPH ไปริมน้ำอะค่ะ